Good afternoon, everybody. Sentara Susan in with you on this terrific Tuesday. I hope everyone's doing well and bundling up. It is chilly because it is February and it means Heart Month. February is Heart Month. Yesterday was Valentine's Day, and we thought it was only fitting to talk heart and bring in one of our cardiologists. Today, we're going to talk with Dr. Kambeez Berenji. He's an interventional cardiologist. He's been serving the community since 2008, very knowledgeable. We're going to talk and then open it up to questions at the end. So be sure to have your questions ready because it's going to be a really interesting conversation today. So let me have Dr. Berenji join us. Dr. Berenji, thank you for joining us this morning. Well, I should say this afternoon. How are you?
I'm doing great. Thanks, Susan. Thanks for having this, and thanks for doing this program to spread the knowledge, and especially Heart Month. Let's talk about the heart.
Definitely. Let's just hop right into it then. Interventional cardiologist. What exactly does that mean? And is there, a certain area of the heart that you focus on or a certain function?
Sure. So interventional cardiologist is one of the subspecialty in cardiology. So after training in general cardiology, I spent 1.5 years and learned how to perform cardiac catheterization. That's the procedure we do to look at the heart artery. And if there is a blockage, trained to fix those blockages with the use of a stent and balloon. So I do take care of patients with general heart problem, heart failure, arrhythmia. But in addition to that, I have training to diagnose and treat patients who have blockage in their heart artery, as well as the other areas.
Wonderful. So we're just going to hop right into it and talk. Let's go into heart attack. What are some of the symptoms of a heart attack? Does that mean that we're having a blockage when we have a heart attack? And I guess it also, the symptoms might vary from the sexes. A man's symptoms may differ than a woman's.
Correct. That's absolutely right. So heart attack I would say 99% of the time means that there is a blockage in the heart artery. There are exceptions. Sometimes we see heart attack in younger people, and especially in women. We'll talk about that later. That's happened because of issue other than blockage, inflammation, dissection. Those are, but commonly when we talk about the heart attack, we're talking about the blockage and narrowing of the heart artery because of building up of the plaque or atherosclerosis. The symptom of heart attack is what we commonly have talked about it, and people mostly know about it, is chest pain. It's the way it's described is as a chest pressure, generally in the left side of the chest, but it can happen in the center a lot of time, as well as the right side. Occasionally, it can happen in the back or other areas such as shoulders, neck. And generally, it's a pressure feeling, lasts for more than few seconds. It can last between 5, 10, and sometimes it's prolonged. Sometimes associated with shortness of breath and fatigue and tiredness. Now, there are some what we call an atypical symptom, and it has been reported that those are generally happen in women. Nausea, vomiting, abdominal pain, sometimes pain in the jaw has been reported. So we do see those symptoms a little bit more frequently in women. And that is a problem because most of the time, those symptoms are not associated. People do not think about the heart attack if they have a belly pain and nausea. And so that's sometimes why the treatment is delayed.
Yeah, I wouldn't have thought of the stomach ache or nausea that maybe was associated with that. Is there any sort of symptoms or maybe tip-offs in the days before a heart attack that, kind of let people know, hey, something's going on, or maybe we just kind of miss?
So it is very interesting because we do hear it from our patient that they have heart attack. One of the thing that I hear sometimes from my patient who are a smoker, that they stop smoking about a week or 2 weeks before their heart attack because they felt something's not right. So the answer to that question is yes. Sometimes what are their sign and symptom is generally shortness of breath, chest pain that does not last as long, feeling tired. And most of those symptoms happen at the time that people are active, because when you're active, when you're doing something, the heart needs more blood. And if there is a blockage in the heart artery, it presents itself at the time. So when you're physically active, doing things that you used to do, and now you're feeling tired, you're feeling short of breath, or possibly feeling a chest pain or pressure. It's not always pain. A lot of people say, I don't have a pain, I have a pressure. We use that interchangeably. But feeling something's not right, especially when you're physically active, can be a sign that there is an issue and it's need to be checked.
It's ironic that you mentioned that about the working out and having the symptoms there, because one of the stories that I'm going to be sharing later this week involves a Sentara patient and a cardiac rehab patient who says just that. He was working out and he felt all of a sudden, he said it was almost like a blow, that he thought, oh man, I need to go lay down. Like, that's how severe and kind of sudden and intense it was.
Correct. So it can. There's different presentation. Everybody's different. We do see most commonly in people who are smoker, and sometimes in people who are have diabetes, that they do not have any chest pain, they do not have any chest pressure, and the only symptom they have is shortness of breath at the time, even before heart attack. And even with heart attack, sometimes they present, they're just short of breath, they don't know what's going on, and it's because of an issue. So those are the things that you need to kind of think about. If you're used to do something and you're now doing that same activity, you feel things are not right, those can be warning sign, and you need to pay attention to them.
Yeah. One of the symptoms I've heard of is heartburn. If you're someone who experiences heartburn on the regular, how do you differentiate that? Can you just think, oh gosh, I ate one of my trigger foods, or I drank one of my trigger foods, and that's what's happening here, when in fact it might be something much more severe.
True. And that's, sometimes it's really difficult, even, when we have to do all those tests and procedure to be 100% sure. But generally, this is a general idea, is that with the reflux, it happened after you eat something. You had your food, and especially if you eat something spicy, something citrus, and those kind of things trigger the symptom. Usually quickly improve after using Maalox or Toms or antacid. The symptom improves. If you lie down, you kind of feel it. You sit up, it's better. But the heart issue, generally those reflux symptom or symptom-like happens when you're physically active or emotionally stressed. So it's not just physical activity, but emotional stress can also bring up the symptom of heart disease. So that would be, I would say, the setup and how, in what situation the symptom happens will be helpful to know if this is more a GI problem or if this is a more heart problem. But as I said, sometimes we need to do tests such as a stress test or other step to make sure that this is, for example, is a heart issue or more a problem with the stomach.
Yeah. When I think a lot of people maybe experience symptoms and then maybe put off going to the hospital because they're concerned that, oh, I don't want to make a big deal. This is nothing. And then I'll feel silly if it is nothing. How bad does it have to get, I guess? Or, any pain should send you to the emergency room immediately? Or I guess, is there a gauge?
All right. So it is hard to, again, generalize, because as we talked about, there are people that don't even have a chest pain. But and again, this is sort of it's a general idea. It's not necessarily an advice, but the idea is the following: is that if you are experiencing a chest pain, it's a sharp pain, you're sitting down, you're not doing anything, 10 seconds, it's all gone, you otherwise feel good. That obviously does not sound to be a heart pain. That's something that you can talk to your primary care physician and make sure that everything's okay and nothing else going on. On the other hand, if you feel a pain that lasts more than a couple minutes, especially if it's triggered by physical activity or emotional stress, if it's associated with shortness of breath, those are the warning sign, and those are things that needs to be immediately evaluated. I do hear that from some of my patients, even people who have history of heart disease, and they're like, oh, I didn't think that this is important. I didn't want exactly what you said. I don't want to make a big deal out of it. And I always tell them that the biggest regret is for people who actually had a heart attack, stayed at home, and we do see them. I would say too frequently, but not that uncommon either. That they had a heart attack a week ago. They stayed home because they thought that it's gonna go away. It's not a big deal, and then they come present, and at that point, we really can't do much. We can still do medication. We can help them a lot, but we can't reverse what has happened with the heart attack. So if the pain lasted more than a couple minutes, if it's in the center of the chest, usually we say from the jaw to the upper belly. No other reason for that. You especially have risk factor. You have diabetes. You're a smoker. Obviously older age heart disease happen more frequently. Those are things that if pain lasts for more than a couple minutes, yes, that may need an emergent evaluation.
Is there such thing as a minor heart attack? I mean, I feel like a heart attack's a heart attack, but certainly we hear about massive heart attacks. So it would stand to reason that perhaps there's minor heart attacks, and would the symptoms pretty much be similar?
All right. So sometimes we do use that term, but in general, what you says is correct. Heart attack is heart attack. Still, there's a damage to the heart, and what we sometimes use those terms is that there are three big arteries to the heart, and if one of those big artery closes off, a large part of the heart gets damaged, and so we call it a major heart attack. Sometimes what happens is a small branch that closes off, and although it's technically a minor heart attack, there's not much damage, but it doesn't mean that that's without complication and risk. We have occasionally seen people that because of a small artery blockage and what technically would have been called a minor heart attack, the heart goes out of rhythm and they had serious complications. So sometimes we use those terms, but I think I agree with what you said, that heart attack is heart attack, and it still put people at risk of sometimes a minor heart attack could be a sign of a major one coming around. So it needs to be evaluated. Those symptoms that we talked about, those are things that need attention. Depend on how, as we talked, sometimes emergently and sometimes a little bit on a non-urgent base.
It used to be said that you should take a baby aspirin a day to kind of ward off a heart attack. Is that still the school of thought?
I would say generally the answer is no, but it has to be individualized. So you're absolutely right. At some point we had this blanket statement that everybody needs to be on aspirin to protect the heart attack. What we have found out, there was some recent study, and what they looked at is that yes, there is some protection against heart attack, but there's also some risk of bleeding, and some of those bleeding can be serious. And for that reason, currently the advice is that you need to talk to your physician, primary care cardiologist, and sort of discuss your risk for heart attack, the risk of bleeding, and make a decision. And we no longer make a blanket statement that everybody should be on aspirin. There are people that still may benefit from aspirin. So I would say it's something that's rather than just giving aspirin to everyone, we need to have that sort of discussion, review the risk and benefit, and then decide. Some people may still need to be on aspirin, and some people should not.
Good advice there. Discuss it with your doctor.
Absolutely.
We've been living in a pandemic for the last, almost 2 years now. It's definitely added a certain amount of stress to our everyday lives. How does that stress affect the heart?
All right. So what we know is that there are two types of stress, and they have different. They both can affect the heart, but a little bit in a different way. So sometimes people go under a significant amount of stress in a short period of time, and what we know about those times is that it can cause some major issue with the heart. There are people that because of that stress develop a condition called stress cardiomyopathy, which means that the heart gets damaged. Luckily, that's a process that the heart generally recovers, but people can get extremely sick. Sometimes it can cause a rupture in the heart artery and cause a heart attack without blockage. We talked about it initially, that there are people that have heart attack without having a blockage, and this is called coronary dissection, has been reported. Now, that's aside, the chronic stress, and I think that's what we have been through during the COVID, can increase the risk of heart problem and heart attack by increasing the blood pressure. What we also have seen is that during the stress, people are not, and this has been, we've seen it during the COVID, people are not exercising as much. They do not eat healthy. They eat a lot of fast food, those comfort food. They stop doing exercise. So we have seen increased weight in our patient. We have seen increased blood pressure, cholesterol, and then, those are sort of adds up and potentially put people at risk of heart problem.
This dovetails into my next question. Is there something that we could all start doing today that would help our heart? Or is it too late? I mean, is the bad eating and sedentary lifestyle has that doomed us?
I think there's a lot we can do, and this has been shown over and over that choosing a healthy lifestyle will be helpful. We have seen it in patients that present after a heart attack. So when we get these people through cardiac rehab, we monitor them, we advocate, and they follow a healthy lifestyle, we clearly see a decrease in the future events. We see people who stop smoking, people who start exercising, people who start eating healthy, that they will decrease the chance. And this is not just a heart attack, even with cases such as arrhythmia and heart failure. So anything related to the heart, with a change of lifestyle, we can change the risk of future events. So definitely, it's never late to start living healthy, doing exercise. It doesn't have to be an intense exercise, even walking, 15, 20 minutes a day, trying to cut the portion of the food, avoiding fast food, eating fresh fruit and vegetable, small changes. And then there's definitely a benefit. We have seen that, and people have done a study and have shown it. Even in people who have major heart attack, major heart failure, major arrhythmia, we can change the course. So let's make that change today.
Hey, that sounds like something we could all do. I understand that there is a test available here at Sentara Northern Virginia Medical Center that can take a look at, perhaps your coronary system to determine if you really are maybe a candidate or a future patient with perhaps heart issues. Tell me a little bit about that.
Sure. For years, what we have done is that with use of techniques such as a stress test, we have been able to detect if somebody has a major blockage in the heart artery. What we define as major is the blockage in the artery more than 50%. So when there's a narrowing more than 50%, we can detect that by doing stress tests or heart catheterization and all those things. But the question for us was that how can we detect the formation of blockage before it's causing symptom, or before we can detect those with doing a stress test, and how can we prevent the progression of that narrowing before it become 50%. So many years ago, people find out that by doing a test called coronary calcium score, they can detect presence of earliest stage of plaque buildup. So what happens is that as the plaque builds up in the wall of the arteries, there is a microinflammation, and the responsive body is to build up some calcium there, and we can detect that calcium. So this is a CT scan with low radiation. There's always with CT scan, there's a concern about radiation, but this is a low dose radiation CT scan. It's a quick test. We don't use any contrast or dye, and therefore we can detect presence of calcium and earliest stage of plaque buildup or atherosclerosis. And then we can start, doing ways to prevent that, sort of intensifying the change in the lifestyle, occasionally start medication, And then sometimes if there's a lot of calcium buildup, we may need to move to the next step and look for other things. So this has been a very, very important tool in our box, and we can detect people in earliest stage and sort of do intervention to prevent future event. The study has been done, and this clearly has been shown to be a very beneficial test.
Sorry, fat fingers. We're back on track. So you had said this is a non-invasive test. So it sounds like it would be rather quick. Once you get in there, they take the
Sure.
pictures, so to speak, and there you go. Who is this test really aimed at? Is it covered by insurance? Because that's usually a question. Is this going to be a couple $1,000 out of pocket expense that really does hurt the average folks?
Sure. No, this is there's some insurances cover this test, some don't. It's not an expensive test, and you can correct me, Susan. I believe it's in the range of $100 to $150 from last time I checked. It's a quick test. There's no, as I mentioned, there's no dye or contrast used during this test, and it's a quick test and gives us a lot of information. Who do we use it for? It's generally people in middle-aged people that have a risk factor for heart conditions such as diabetes, high cholesterol, hypertension. This is typically, I would say, in the age of 45, 50 to 60. That's sort of the range that we, sometimes we do it for people older or younger, depending on their risk factor and what we're trying to achieve. But I would say generally middle-aged people with some risk factor, family history. There are people who have family history for heart disease. So those are people with some risk factor. They don't have any symptom. And what we trying to do is we try to screen them and find out issue with the heart before it causes problem.
Okay. Well, let's switch gears a little bit, because I know a topic near and dear to your heart as medical director of the Sentara Cardiac Rehab Center. It's doing amazing things. And so who winds up there? What, usually what procedure? Do you have to have a heart procedure? Have you had a heart attack? Who's the ideal patient there? And tell me just a little bit about it.
Right. If you ask me, I would say everyone needs to be involved and get into the cardiac rehab. But there are criteria that we use. But as I said, I truly believe that everybody will benefit from that program. Now, what we use is the criteria that's set up, and people who had a heart attack, people who had a stent in their heart, or they had a bypass surgery, people with heart failure, and that's something that people may not know about that. People with heart failure that have decreased heart function. So there's people with different type of heart failure, but one class of people who have a decreased heart function with heart failure, there are another group that will benefit from cardiac rehab, and they can get enrolled. So heart attack patient who had a cardiac procedure, including bypass surgery or a stent, and people with heart failure with decreased heart function or decreased ejection fraction.
Okay, great. Well, let's open it up, because I see a number of questions here of some folks that, just had some questions, general questions. Now, certainly, this is to just a blanket statement that we can't do any diagnosis here, because your doctor would have a whole host of tests and take those things into account along with your personal history. But, we'll touch on some topics here. Donna says, I'm diagnosed with atrial tachycardia. Can you explain what causes this? And Dr. Berenji, what exactly is that for those who don't know and aren't familiar?
So atrial tachycardia is a type of arrhythmia, and basically what happens is that there is a part of the heart in the top part of the heart. If I may show my model of the heart here. So with the atrial tachycardia, basically there's a focus in the heart, generally on the right side of the heart, in the top part of the heart, that generate extra pulse. And this can be sometimes triggered with other heart condition, and sometimes it's something is spontaneous. There's no other cause for that. And the result of it is a fast heartbeat. A lot of time can be treated with medication, but occasionally need a procedure called ablation.
Okay. Would this be something where you would involve like a shock to the heart in some cases to kind of get it back on, a normal rhythm, or is that ablation kind of takes care of that usually?
Generally, medication and ablation. The rare occasion that shock therapy may be used, but it's generally either medication or an ablation therapy.
Okay. Another question from Irene. She asked, have you seen an increase of heart attacks since the COVID pandemic started?
That's an interesting question, because what happened is that when the COVID hit back in 2020, for a long period of time, for several months, we didn't have any heart attack patients. And I even remember in a national newspaper, there was a editorial asking where are the heart patients, what happened, maybe we're doing too many tests and procedure. So for several months, we didn't see patients with heart attack. And then the gates open up. Then we just saw a lot of patients with heart attack, and that's kind of persisted. So I think that there was a period of time that people will avoid going to the hospital. And maybe for other reason that I don't know, but there was a period of time we didn't see that many patients. And then after several months, we kind of see a reverse and an increase in the number of heart attack patients. And I think part of it, we talked earlier about the stress. We talked about the change in lifestyle, not having regular follow-up with your physician, all the things that happened during the pandemic. And I think we're still seeing the effect of that.
Yeah, I know that, we certainly are seeing some very sick people coming to the hospital that have nothing to do with COVID. And it does seem that a lot of folks try to stay away from the hospital because perhaps they were concerned about COVID. So, maybe they put off that regularly scheduled scan or put off that doctor's appointment. But, it is so very important that you do see your doctor, that you do keep those appointments. And if you had to cancel them, please reschedule them, because it really does make a difference in your health rather.
Correct. That's critical. We started this, and a lot of other practices sort of providing those telehealth visit and trying to keep in touch. It's I'm sort of old fashioned, and I still like to see patients, feel their pulse, listen to their heart. But again, it's the reality of the current situation, and trying to keep in touch with your physician. Just even a phone call will help to make sure that things are stable. So we definitely have seen the effect of those first few months that people were just kind of, and it's, again, for good reason, what happened after.
Definitely. Another question we have, Darlene asks, is angina a form of heart disease? And once again, what is angina?
So, and when we say angina, we talking about the chest pain or chest pressure that happens because of blockage in the heart artery. So that's the sort of classic definition of angina, as a chest pain or chest pressure that generally happen with physical activity, and the underlying cause of that is because of blockage in the heart artery. Now, sometimes we talk about shortness of breath being an angina, but yes, that's a symptom of blockage in the heart artery, either chest pain or sometimes shortness of breath.
But maybe not officially heart disease, or would that be considered a type of heart disease?
When generally it's a medical term, and when physicians use that as angina, they mean that the chest pain or shortness of breath is because of the blockage in the heart artery. But sometimes in community, people use that to just say chest pain. But if officially, that means a chest pain or shortness of breath because of blockage in the heart artery.
Okay. Laura asks, should I make an appointment with a cardiologist for a baseline if I'm in my 50s with no documented problems, or should I just continue to see my primary physician?
I think that's something that's the best option would be to talk to your primary care physician and ask their advice. If you have no risk factor, meaning that you're not a smoker, you don't have diabetes, high blood pressure, no family history of heart disease, you're active, generally the primary care physician can, handle issue, but they may decide that you may need some sort of follow-up or attention. So my advice would be to discuss with your primary care physician and see if they think that this is necessary in follow-up or attention.
Yeah. Usually, you have that yearly physical, which involves perhaps an EKG. And I would imagine that's where you would perhaps see that maybe something was wrong if that needed to be escalated to a cardiologist or a specialist.
Correct. That's generally the case. At the same time, if somebody would, still worried, and we do sometimes see patient, they had a relative that suddenly had a heart issue, and heart disease unfortunately sometimes happen. So, but I would say my first step would be talk to your primary care physician, and if you have a concern and things like that, generally they are receptive, and they can sort of send you if needed to see a cardiologist.
Great. Is vein health connected to heart health? Yeah, that seems like that's from Donna. She says, is vein health connected to heart health? These are all typical questions that are asked, she says.
So I'm not sure exactly the vein health, if this talks about the varicose vein and issue. Typically, they are not related to things that we talked about, the blockage in the heart artery. There are some conditions that are generally not very common that there could be an association. For example, DVT, if you have a blood clot, that's a different story. So if somebody who had a blood clot potentially can be at higher risk of having blockage in the heart artery or heart attack, that has been reported. But if you're talking about vein health and varicose vein, we don't typically associate them with heart disease.
Okay, great. Just to clarify, somebody had asked us to use or say the name again of that heart scan, and it's called coronary artery calcium scoring, sometimes called a CT heart scan, coronary calcium scoring.
Yes, coronary. We usually call it coronary calcium score.
Okay, great. Another question I see here on the message boards. Can you tell us a little bit more about broken heart syndrome? Is that a thing? Is that a true thing?
Correct. If you remember, we talked about people who go under a large amount of stress in a very short period of time, and it can cause a cardiomyopathy or a stress cardiomyopathy. So for the reason that we don't know exact detail of that, with the changes that happen in the body because of that stress, sometimes we see people, they hear the news of death of a loved one. That sometimes we see that, or they hear a really bad news. And with all the changes that happen in the body, the heart gets affected, and they present to the hospital generally with chest pain or shortness of breath. Sometimes it's very hard for us to differentiate and say if this is a broken heart syndrome or stress cardiomyopathy or it's a heart attack. And sometimes we have to take them immediately, take a look at their heart artery, make sure that there is no blockage, because again, it's sometimes difficult for us to differentiate between the two. And if we don't see any evidence of blockage, and at the same time we see that the heart is not functioning right and there is a decreased function, we make that diagnosis. Generally recovers with close monitoring and treatment. In the immediate phase, can be dangerous, can cause complication. A lot of time people recover. The only thing that can happen is that this can happen again. So that's sort of the broken heart syndrome. So it is a real thing, and we have noted that it does appear that it may happen more in women than men.
Okay. Well, we're starting to wrap it up because I know you're a busy guy. You've got a lot on your plate over there. But as we do wrap up today's session of Lunch and Learn, what do you hope that everybody takes with them, even if it's just one little nugget as we leave talking heart health?
That you can make a change, that there's no question that by making even the smallest steps, you can improve your heart health. Walk more, exercise more, eat healthier, and try to relieve the stress. That would be my suggestion and recommendation. Small change, you will see the result.
That's awesome. Great. Well, thank you so much, Dr. Berenji. To learn more about the Sentara Heart and Vascular Center and the programs that we offer here at Sentara Northern Virginia Medical Center, give us a call at 703-523-1980, or you can visit sentara.com/heart. Thank you all so much for joining us. Dr. Berenji, thank you so much for all the great information. You were fantastic with the responses, and I think it was a lot of information that we all could take in and really ponder and hopefully know moving forward that if heaven forbids, you do start to feel a little something, that, don't sit on it. Go see a medical professional, go to the emergency department. You'd rather say, oh, it was just indigestion, instead of a heart attack that damages your structure. So thank you so much.
Thank you so much. And thanks for Sentara. Thank you.
Okay. Thank you very much. Goodbye, everybody. We will catch up with you next month when we talk aquablation and urinary health. Take care.